Okay, I think we'll go ahead and get started with the introductions, and I'm sure we'll have more people joining us as the presentation continues. So hello, everyone. I'm Ursula Marinelli. I'm the Executive Director of the Pacific Communities Health District Foundation here in Newport. Welcome to all of you to Samaritan Health Equity Initiatives with Earlean Wilson Huey. Today's MedTalk is presented by Pacific West Ambulance, and they are a Samaritan Foundation's Pride partner. So MedTalks are meant to be interactive, so please feel free to ask questions by either raising your hand with the hand icon at the top of your screen or by typing into the chat. If you are on the phone, you'll just have to verbally ask your question when there's a break in the conversation. If you're not speaking, please remember to stay in the mute mode. So are there any questions about any of that? All right, good. So now I'll introduce our presenter. Earlean Wilson Huey serves as the Diversity, Equity, and Inclusion Manager for Samaritan Health Services. She received her Bachelor of Science degree in biology from Grambling State University and her Master's in Public Health from Oregon State University. Mrs. Wilson Huey completed the Developing Equity Leaders Through Training and Action, or DELTA, program, and is currently completing the American Hospital Association's Certificate in Diversity Management program, as well as the George Washington University's Together Equitable, Accessible, Meaningful Cancer Care for Sexual and Gender Minority Patients training. Prior to joining Samaritan Health Services, she worked for both Oregon State University and the Oregon Pacific Area Health Education Center. Mrs. Wilson Huey resides in Lynn County with her husband, 4 adult children, and her first grandbaby boy. So now I will turn the floor over to our presenter.
So, hi everybody. Thank you all so much for coming. As Ursula mentioned, I'm Earlean Wilson Huey, and I just wanted to say thank you, Ursula, for thinking of me to do a presentation for you all. So I'm glad to be here with you all, Samaritan family, and so let's get it in. We got an hour. Hopefully I will drop some seeds that resonate with you. And that you find that this is a good use of your hour with us. So just a brief overview. An hour does not do justice to trying to talk about health equity, disparities, inequities, et cetera, et cetera. So it's going to be a brief overview, and we'll just learn about some of the current initiatives that are happening around diversity, equity, and inclusion at SHS. So before we start, I'd like you to put in the chat the responses you think are to these questions. And these are from the Unnatural Causes page. It's just 5 questions. I think there's a total of 15 questions. I thought it would be good to kind of break the ice and start it off with a little quiz. So here we go. Question number 1. How does American life expectancy compare to other countries? Is it A, number 1, B, in the top 10, or C, 29th place? And Ursula, I can't see what folks are saying, so you can let me know what folks are thinking. Just another half minute. What's the majority saying? Or what are you seeing?
Yep, the majority are saying C. Everybody actually is saying C.
Awesome. The answer is C. At 77.9 years, we are tied with South Korea and Denmark for 29th through 31st place, despite being the second wealthiest country on the planet. Japan has the highest life expectancy at 82.3 years. Question 2. How much does the U.S. spend per person on healthcare? Is it A, 3/4 as much as the other industrialized countries, B, the same as the other industrialized countries, or C, more than double other industrialized countries? I'll play the Jeopardy music. Do, 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 do. Another half a second. All right, Ursula, what do we see?
Okay, it's primarily C. We did have a couple of A's.
Okay, the answer is C. It's more than double. We spent $6,102 per person on medical care in 2004. The estimates for 2007 are $7,600. They didn't have any more current data, so this is the quiz that they had on. I'm not sure if they're doing any updates to it, but that's more than double the 2552 median of the other 30 countries, yet our health outcomes are among the worst. Question 3. On average, how many more supermarkets are there in predominantly white neighborhoods compared to predominantly Black and Latino neighborhoods? Is it A, about the same, B, 2 times as many, C, 4 times as many, or D, 6 times as many? Another half second. All right, what are we seeing?
We are seeing D's, B's, and C's.
Okay, we're all over the map. All right. The answer is C, 4 times. Predominantly Black and Latino neighborhoods have more fast food franchises and liquor stores, yet often lack stores that offer fresh, affordable fruits and vegetables. So I grew up in Southern California, Linwood, California, and in my neighborhood, they could be 4 liquor stores in a 1 block radius. So right around, across the street from each other. Employment opportunities were limited. There were some. I was actually pretty blessed. My street in my community, the street that I grew up on, all the kids on the street, we all had both of our parents in the home with us. So that was, it's not rare, but it wasn't as common as, folks would say. On average, I think this is question 4. On average, which of the following conditions is the strongest predictor for your health? This is number 5. A, whether or not you smoke. B, what you eat. C, whether or not you are wealthy. D, whether or not you have health insurance. Or E, how often you exercise. What do y'all think? Another half second. All right, what are we seeing?
We're seeing C's, B's, and E's.
Okay, again, all over the map. The answer is C, whether or not you are wealthy. The wealthier you are on average, the better your health. From the bottom all the way to the top, genes, diet, exercise, and other behaviors are important, but a poor smoker still stands a greater chance of getting ill than a rich smoker. So as we engage in talking about diversity, equity, and inclusion, just a few definitions. So health equity means that everyone has a fair opportunity to live a long, healthy life. It implies that health should not be compromised or disadvantaged because of an individual or population group's race, ethnicity, gender identity, income, sexual orientation, neighborhood, or other social condition. So what is health equity? We just went over the definition. It's the differences in health that are avoidable, unfair, and unjust. Health inequities are affected by social conditions, and they occur when a person or group is treated unfairly because of those demographics, race, gender, class, sexual orientation, or gender identity. Even when access to care in equal racial and ethnic minority patients often receive lower quality care than whites. Minority men, 17%, and women, 18%, experience fair or poor health at higher rates than all men, 11%, and women, 12%. Also affected by economic conditions. So institutions such as governments, churches, or schools use their authority to create unequal opportunities can lead to poor educational outcomes or fewer job opportunities. So only 9% of students from the lowest income group finish college as compared to 54% from the highest income group. Also can be affected health inequities by environmental conditions. So where you live can determine how healthy you are. Why? Because lower income neighborhoods tend to be in poor social, economic, and physical condition. So lower income neighborhoods tend to have fewer safe places to exercise, limited access to healthy food, poor schools, and limited job opportunities. In Marin County, California, there's a 15-year life expectancy difference in just 8 miles, reflecting the impact low-income neighborhoods have on health. Okay, health inequities. There's differences in health status between more and less socially and economically disadvantaged groups caused by systematic differences in social conditions and processes that effectively determine health. Health inequities are avoidable, unjust, and therefore actionable. So health disparities. Health disparities are differences in health outcomes among groups of people, and they are affected by health inequities, which are the differences in health that are avoidable, unfair, and unjust. They are a result of social, economic, and environmental conditions. Again, they gave that 15-year life expectancy in Marin County. They also are affected by health behaviors, which are influenced by health inequities. Smoking, poor nutrition, and lack of exercise are all behaviors that may lead to poor health. Hispanic adults are less likely to receive advice from a health provider to quit smoking than a non-white Hispanic adult. Health disparities can lead to disease or injury. Chronic disease or injury are a result of inequities, behaviors, and genetics. Smokers are 2 to 4 times more likely to develop heart disease than non-smokers. They also can lead to mortality. Health inequities and health disparities affect how long someone will live. So the life expectancy for a smoker is at least 10 years shorter than for non-smokers. So structural inequities. Those are structures or systems of society, so such as finance, housing, transportation, education, social opportunities, etc. They're structured and set up in such a way that they benefit one population unfairly, whether intended or not. So who's affected by structural inequities in Oregon? American Indians, African Americans, children, persons with mental health challenges, folks from an LGBTQ community, immigrants, refugees, Asian Pacific Islanders, Hispanic Latinos, rural Oregonians, women, older Oregonians, persons with disabilities, and more. So quite a few folks are impacted by structural inequities. So I'm not sure if you all have seen this. I wanted to show you a brief history of US and Oregon laws based on race.
1681. The label white first appears in law in an enactment passed by the Colonial Assembly of the Colony of Maryland. 1787. Slavery is legalized. Black persons are considered 3/5 human. 1790. Naturalization Act limits citizenship to only free white people. 1831 to 1838. The Trail of Tears. Forced relocation of Native American nations. 1844. Oregon says no to slavery, but, quote, blacks and mulattoes are not allowed to live here. 1844. Oregon Lash Law. Black people are banned from the territory. Violators are threatened with 20 to 39 lashes across the back every 6 months until they leave. 1850. Oregon Donation Land Act offers free land to, quote, whites and half-breed Indians. 1862. Homestead Act. The U.S. sells Native American land to settlers. 1862. Oregon residence tax for all black people, Chinese, Hawaiians, and, quote, mulattoes. 1862. Oregon bans interracial marriages between whites and anyone a quarter or more black. 1864. The 13th Amendment to the United States Constitution abolishes slavery. 1866. Congress passes the Civil Rights Act of 1866. 1866. Oregon does not pass the 14th Amendment granting citizenship to black people. 1870. Naturalization Act of 1870 excludes Asians and Native Americans. 1870. Oregon does not pass the 15th Amendment granting voting rights to black men. 1871. Indian Appropriations Act dissolves Native American tribes as nations. 1876. Jim Crow laws enforce racial segregation. 1878. Supreme Court rules that Chinese are ineligible for citizenship. 1882. Chinese Exclusion Act prohibits all immigration of Chinese laborers. 1887, Dawes Act dissolves tribal land and provides parcels to individuals. 1896, Plessy versus Ferguson upholds separate but equal laws. 1901, U.S. citizenship is granted to the 5, quote, civilized tribes. 1917, Immigration Act of 1917 bars Asians and all immigrants over the age of 16 who are illiterate. 1922, Takao Ozawa is denied citizenship. The Supreme Court majority does not consider him to be Caucasian or white. 1923, Bhagat Singh Thind, who fought for the U.S. in World War I, is denied citizenship because although he is Caucasian, he is not considered white in the traditional sense. 1923, Oregon Business Restriction Law allows cities to reject business licenses for Japanese Americans. 1924, Indian Citizenship Act grants full U.S. citizenship to Indians. 1924, Immigration Act of 1924 denies legal U.S. entry to Japanese people. 1926, Oregon repeals exclusion law allowing black people to live in the state. 1927, Oregon allows black people and Chinese to vote. 1930 to 1940, U.S. deports 600,000 Mexicans, including American citizens. 1935, Oregon law segregates Mexican students of Indian descent, not fair-skinned descendants of Spaniards. 1935, National Labor Relations Act protects workers' rights, but excludes farm workers. 1942, President Roosevelt signs Executive Order 9066, sending 120,000 Americans of Japanese ancestry to incarceration camps. 1951, Oregon repeals law prohibiting interracial marriages. 1954, Brown versus Board of Education of Topeka declares separate schools for black and white students unconstitutional. 1957, Little Rock 9. Arkansas governor blocks 9 black students from Little Rock High School. 1957, Oregon Fair Housing Act declares it unlawful to discriminate solely because of race, color, religion, or national origin. 1964, President Johnson signs the Civil Rights Act of 1964. 1965, Voting Rights Act outlaws discriminatory voting practices. 1967, Loving versus Virginia invalidates laws prohibiting interracial marriage. 1968, Civil Rights Act of 1968 outlaws housing discrimination. 1988, President Reagan signs Civil Liberties Act of 1988, granting reparations to Japanese Americans incarcerated during World War II. 1991, Civil Rights Act of 1991 strengthens the 1964 Act by providing the right to trial on discrimination claims, among other provisions. 2002, Oregonians vote to remove all racist language from its constitution, including the clause, "No free Negro or mulatto not residing in this state at the time of the adoption of this constitution shall come, reside, or be within this state, or hold any real estate." 29% of the voters opposed removing the language. 2013, the Supreme Court strikes down the heart of the Voting Rights Act of 1965.
Any thoughts about the video? I'm not sure if you all have seen that before, if it was new. What resonated or what came up for you looking at that video? You can put that in the chat. Is this the first time folks saw this video? Or you saw it before? I wanted to also read an excerpt from this book entitled Just Medicine, A Cure for Racial Inequality in American Healthcare, and it's by Dana Bowen Matthew. And I'm trying to set the stage to show you just how far back and how deep the roots of inequality, inequity, health disparities go. Nobody in this room started it. We didn't create it. We didn't write these laws, but we've inherited these things. And oftentimes, these are the things that aren't taught to us in school, so we don't even know that some of this stuff exists. So I'm going to start off as the caption is the colonial period, the hegemonic role of law. At the dawn of our nation's history, neither Europeans nor their American descendants regarded non-whites as fully human. Thus, European law protected the health of minority persons in much the same way the law might control the health of cattle or yard dogs. For example, Thomas R. Cobb, a successful Southern lawyer, described English slavery legislation in his defense of slavery titled An Inquiry of the Law of Negro Slavery. Cobb reported that an act of British Parliament restricted the number of slaves to be carried on a ship to 5 for every 3 tons, up to 201 tons. And by the same act, a well-qualified surgeon was required on every vessel because disease frequently made sad havoc among the poor creatures. Generally, American law evolved to reflect a similar estimate of the humanity of non-whites. Early American law worked to facilitate the subordination of Native Americans, Blacks, and other migrants in the service of the white settlers' emerging political economy. The laws that affected minority health and healthcare during this period reflected the prevailing culturally approved views that Blacks were no more than wretched creatures, and in Thomas Jefferson's words, as incapable as children. Native Americans were deemed fierce savages, and in Andrew Jackson's words, lacked appreciation for the cause of their inferiority. The American legal system viewed people of minority descent as subhuman and thus disregarded their health accordingly. Any thoughts on that passage?
Earleen, I will tell you that some people did respond to your question about the video and said for a few of them, it is the first time they're hearing some of that information, finding it appalling, disheartening. And then one person writes that she's shocked by the percentage that oppose the Constitution change. And I have to admit, I am too.
Yeah, and like I said, none of us created this, but these kind of like the times that we're in now have all been kind of, there's this foundation that was set and established, and we just inherited it. You know, we get all kind of messages that come through us through the media, through our schooling, through the things that we hear from our parents, and it's all how we're socialized, and our socialization is based on a foundation that wasn't based on equity. It wasn't based on fairness. And so those are the things that we have inherited today. And often, because many of us don't know, we're learning. And it often, when we try to engage in conversation, it can be a bit challenging, you know, because we don't often engage in a conversation. It brings up emotions. People are fearful of talking about these things openly. What if folks think that I'm racist or I'm sexist or I'm homophobic? That fear, can I trust that what I share with whoever I'm interacting with, are they going to keep it confidential? Are they going to spread it throughout the workplace? And then what folks think of me? So there's all kind of things that kind of get in the way of us really engaging in those courageous conversations. A lot of it is due to fear. What if I say the wrong thing, or I don't want to offend someone? And so those are kind of emotions that kind of keep us a bit stuck. And because we don't really kind of talk about it, it's like this wound that we pretend that it's healing, but it's just festering and it's pus and it's all this kind of yuckiness that's coming over, and we put a Band-Aid on it that's barely covering it up, and it's still just worsening. So could you go to the next slide, please, Ursula? What you're about to see is, I came across this project. It's called the 400-Year Project, and it was students at, I'm trying to remember which university was it. Oh gosh, I'll have to get back to you on the university. But they did it for a class project, and what they did was just combed all the different kind of historical records to pull together this kind of timeline that's for 400 years of, it's called 400 Years of Inequity, an observation for a just future, 1619 to 2019. And it's actually pretty cool. Again, kind of like the health disparities, little graphics in there. It's a little glitchy, but I wanted you to see it because it was a massive project and it's very thorough, and it might be something you all might find as a resource, and I can put the link into that.
Could we talk about language differences perhaps for a moment?
Sure.
Because I was born in another country and I learned to speak the King's English. So I always made sure I spoke English properly. And initially, when I was younger, I had a disrespect for people that didn't speak English the same way as I did. And then after studying, the languages I had to study in school, I learned to treat other ways of speaking English with the same respect that I would learning French or Russian or Japanese. And I think sometimes we forget that different ways of speaking are just as well respected as what we may have learned in our, second grade grammar books.
Mm-hmm.
I was wondering what other people thought.
One thing I would share is, because the climate of our nation, unfortunately, is one that is not often welcoming. And so, sometimes you may go to a bank teller and it's like English only, or you may overhear conversations where, someone would get upset that they're hearing another person speaking in their native tongue, whether it's Spanish or Chinese or Farsi or what have you. But we haven't been, as a nation, very tolerant of differences. And that's obvious in how we view others who are not like ourselves. The messages that we get in media, if you go back and look at old cartoons that you grew up on, look at the how people who aren't white, people of color, how they are portrayed. If you see how Africans, usually you'll see them in the jungle, or they're boiling white people in pots, or they have big bones in their nose, their lips are oversized. You'll see Asians with their eyes really slanted. Then you have images of the lazy Mexican. And so these are the kind of things that we were kind of grew up on. You'd see cartoons where Bugs Bunny, Mickey Mouse, Minnie Mouse, everybody was blackening their face, doing blackface. But because, we don't challenge it, when we're looking at TV or whatever, usually it's to be entertained. And so we're not sitting there trying to critically think, well, what does that image mean? Why is that image? We're not questioning those things that are coming to us. And so all of the messages that are being received, they just go into our subconscious unchallenged, and they can anchor themselves and solidify and become beliefs for us, if we see them over and over and over again. I'll challenge you all to go back and you can even get on YouTube and look at some old cartoons and just look at some of the images. You can even look at some of the mainstream films, a lot of the stereotypes that go into there, and those things get reinforced. And we just play them out, and we talk about unconscious bias. If we've been fed this diet of all of these stereotypic images, messages, and we don't challenge it, we get those messages from those folks who we trust. We believe it because we trust them, whether it's coming from our clergy or our grandma, our sweet grandma. Sometimes they say some things, you'd be like, oh my gosh, grandma, but those are the things. And, we talk about folks being products of their time, but the products of their time, I should say, and the products of their time, were those where you had openly racist things, you had openly sexist things happening, and incidences and homophobia. And so we have this climate, you know, that again, because we don't really engage in, sometimes we don't know how to interrupt when we hear something that we think might be wrong or sound wrong, or it's just not sitting well with us. And, you know, how do I tell my dad that, you know, Dad, it's not okay to say that, you know, that's not cool. You know, how do I interrupt that? Or how do I interrupt something going on with my family, you know, because I don't want to be ostracized from my family, or I don't want to be ostracized from my friends. And that's where that kind of bravery comes in, you know, really. And some people are testing the waters, but we don't have enough people, you know, trying to interrupt. And I think sometimes because many folks don't have the skills, they don't know what to say or how to do it, or what if it goes wrong, or, you know, what if I lose my friend or my family member or something like that. And I put in the chat a link to where you can go back and access it. And again, I just wanted to show you this timeline that they had documented all of these different issues that happened throughout history. And it's really pretty informative. And so you might look at this as a resource to just kind of get an idea of some of those things that have happened in the past that still shape and impact us. Could you go to the next slide, please? This one is a video, and it's about the importance of health equity. Why? Why does it matter?
Health equity is really about justice. To me, it's at the core of what we are supposed to be about as healthcare providers. It's about ensuring that every patient that we see has access to not just quality care and the best care, but the care that's appropriate to them. That it's not distributed in ways that some are left out. Fundamentally, my role as a clinician is to make sure that my patient has what he or she needs to be the healthiest that they can be. But my patient could be anybody. It's not based on class, and it's not based on where they live. My patient could be anybody. And that equity is about making sure that everyone has that access. Everyone can be healthy. It's interesting when people start to think of who should and who should not have access to health care. And oftentimes when people engage in that conversation, they forget the privilege that they bring to that situation. They forget that they are privileged to have access to a job, or access to insurance, or access to providers who are not going to look at them differently or treat them differently. It's interesting to me because when their social situation changes, all of a sudden they're sort of enlightened to, oh my goodness, this isn't fair, this isn't right. They start to understand that privilege allows you to put a blinder on so that you don't see the other person's situation. And understand, you know, there's a saying there, but for the grace of God go I, that we could all be in that situation at any point in time. The other part for me is important is understanding that when we leave people out, we are worse off. We're worse off as a community, we're worse off as a society. What we need is the best of everyone to be able to contribute to the richness of what makes us who we are, what makes us who we are as a nation, as an organization, as a community. But you can't have that if people don't have access to good care. When addressing issues of equity and of justice, when we think about health disparities and we think about diversity, these are daunting problems. These are not new problems. And one person alone can't take on that challenge. That doesn't mean one person shouldn't try to do something where they are. But it's the collective that can make change. It's when the I's come together to form the we's that you have the power to make a difference. And so no one should ever feel this burden of I have to do it by myself, but understand that together you can make a difference. Together we can move more towards equity. Together we can move more towards social justice.
Okay. Can we go to the next slide? I would have liked to unpack that a bit, but we are limited time. So I just wanted to just go over the building blocks for health equity. And you know, at the base, that's the foundation. This is looking at the foundation of building health equity within our organization. And so we're looking at culturally competent staff and providers, diverse leadership and staff, community wisdom and equity research, equitable contracting and procurement. You go up to that second to the last tier, standardized, actionable, granular metrics. We know that not every patient, everybody can't get the same care because everybody has different needs. So making sure that our folks get those things that they need for them to attain their best health. Diverse, dynamic community partnerships, community capacity to promote equity. You go up to that second tier, proactive media and communication. So we're talking about this. We are walking our talk, if you will. We're trying to do that. Health equity policy, development and analysis. And at the top is the culturally and linguistically appropriate service, or the class standards. We just spoke briefly about language. We aren't providing great care if our patients don't understand what we're saying. We aren't providing great care if they get a prescription in English and they don't read English. So how are they gonna be able to follow through on that? You know what I mean? And so really building the foundations for our journey, because we're new on the journey, you know. We kind of late to the party, but we're not the only ones. We at the party now. And so what are we gonna do with it now that we're here? We're gonna show up, show out, meaning that are we gonna really dig in deep to create the type of organization that we want our organization to be open, accepting, and welcoming of anybody who comes through our doors. How we want to be as we relate to each other, staff to staff, you know, open, honest, not hostile, you know, able to communicate if we have disagreements, being adult enough to agree to disagree, being able to work even though we may disagree, to still work together within the best interest of our patients, within the best interest of our organization, so that we can be the provider of choice. We want to be the place that folks want to come, not that we're the place that this is the only place in town. You know what I mean? So building the type of culture that we want to have within our organization. Could you go to the next slide, please, Ursula? Equity checks. So when we're at the table, the decision-making table, making policies and plans, we just talked briefly about some of the laws, you know, who was at the table making those laws. When we're at the decision-making table and we're working on projects, taking into account, you know, who is most impacted by this issue that I'm working at? Are the right people at the table? Are we asking the right questions? Who's being heard and who is left behind? Could you go to the next slide, please? That's process. In terms of outcomes, as things stand now on this issue, who benefits or who is burdened? What do we hope the outcome will be? Under our proposal, who benefits, who is burdened? If we really value racial and social justice, what would we do? Asking these questions as we're sitting around the decision-making table, making plans for our patients, making plans for our other staff, you know, how are folks impacted, are going to be impacted by those decisions that we are making. Next slide, please. We're going to skip this one. This one, as you know, when you start talking about diversity, equity, and inclusion, sometimes you're going to have, sometimes person may say the wrong thing. I'm not immune to having foot and mouth syndrome and having to apologize when I misspeak, or if I offend someone unintentionally, you know, but being adult enough to sit there and own it, take accountability for it, and be able to move on, and being sincere in that. You know, we can feel sincerity when folks, and we can feel when people aren't being genuine, and it's hard to accept an apology that's not genuine. You know what I mean? Next slide, please. So in terms of our equity and inclusion plan goals, we had goals centered around the strategic pillars. Around employee engagement, we wanted to develop opportunities for folks to be able to participate in diversity, equity, and inclusion activities. One of the things we're working to create our employee resource groups. We'll have an opportunity to start 5 up this year. We're working on getting that policy solidified and seeing how we can make that work. How will staff be able to participate if they choose with their manager's approval? Around quality and service excellence, we wanted to look at the diversity of our workforce. Does it reflect our community? Now, sometimes people might get a bit, it might feel a little uncomfortable when we hear diversifying our workforce, making sure that it reflects our community. Because sometimes people may hear, well, you mean that as a white person, I'm going to have to give up my job. That's not what that means. There are always positions coming open. You know, how are we feeling those? How are we looking at our organization? And it does not mean that you hire someone that just because they're a person of color, they may have low skills. Because some people think that, you know, the two go together. Person of color, low skills. They could have great skills. You know what I'm saying? And so, and it's not just people of color. It's a diversity of everything. Folks with just different abilities. Folks who are LGBT, whatever that diversity of our community reflects, we want that to be reflected at the leadership level as well. We want to really get our language services up to par. We know we have some holes that we are working on. Right now, the policy work instructions for the language assistance interpreter services is with the policy committee, making sure that it lines up with the policy so that staff know, okay, how do I access an interpreter? How do I use the video, the iPads? Who do I call? Who are the vendors that I call? How do I work with an interpreter? All of those things. We want to have it to where sometimes there are issues, you know, there may be bias incidents that's happened. We want to make sure that folks know how do I report those things? How do I track it? We want to look and see what are folks reporting on, what's happening so that we can be able to monitor and make repairs for it. So what are those issues that we need work around? And then we wanted to offer some learning opportunities for our staff around diversity, equity, and inclusion topics. We are working with professional development, Dave and myself and Roxanne and our Equity and Inclusion Council. We're partnering with Oregon State University to create 2 new computer-based learning modules that we will look to release this year and going forward in the future. So we are working on the training, what type of topics. So also, if there are topics that you are interested in learning about, we're creating our intranet for diversity, equity, and inclusion, and we'll have a contact us page for you to provide feedback. Please let us know what you're interested in learning more about so we can create those opportunities. In terms of sustainability, we wanted to make sure that our Equity and Inclusion Council is sustainable. We created the by department. I'm a department of 1, but we just got the approval to get another staff person because, again, as Dr. Reed mentioned, this work cannot be done in isolation. I'm gonna tell you straight up, I can't do this solo. I need everybody, and equity is not something that is done in the silo. So it's not just the work that's coming out of diversity, equity, and inclusion office. It's something that needs to be infused through all of the departments, through all of our whole organization, something that is discussed in our meetings, you know, like you have the safety moments. Do we have a equity and inclusion moment, you know? And we want to create those partnerships, you know, so that we are out with our community, working with the community versus the community having to always come to us. So we want to be in partnership, and being in partnership meaning that we are outreaching to them. We want to hear from our patients, you know, what around language services, you know, how are you experiencing it? What's working well? Where can we improve? We want to get that feedback, and we want to apply that feedback and make those improvements as necessary. What what else is happening. Ursula mentioned Samaritan was one of 6 cancer research centers in the country to be accepted for a George Washington Together. It's a cancer program for sexual and gender minorities. I'm spacing on the acronym right now. But we are being trained by subject matter experts that will be able to bring those learnings back. And so how are we talking about creating an inclusive and open and welcoming environment for our LGBT community? That's one of the ways. We just recently joined a health equity collaborative with the state of Washington hospitals as well as Oregon, and to come together and learn. There are some hospital systems that are further than us because they've been on the journey longer, and there are some who are just starting, some who may have started last year. We started in 2019. And so again, coming together to learn and share best practices of how we all can be better from a diversity, equity, and inclusion standpoint. We're at the time, you all. So if you have questions, my contact information is in here, Earleen E. Wilson Huey at samhealth.org. I welcome your feedback. If there are things that you are interested in learning about, please share with me. If you say, your presentation sucked, tell me that too. That's how I grow. So let me know what worked, what could be improved on. I hope you found this to be a good use of your time. I thank you for sharing your time with me, and have a great week and a weekend.
Thank you so much. I want to thank, on behalf of the Samaritan Foundations, thank everybody for joining us. You will be receiving an email in the next week or so with a recording of this session, and then also a survey. So that's a great way for you to be able to provide that feedback. And of course, as Earleen said, you're always more than welcome to just reach out to any of us in the foundations or directly to Earleen. Okay.
Bye, everybody.
With that,